know that the current imaging available, the available imaging modalities are almost the same like the esophagus, including the barium studies, the endoscopic ultrasound, CT, MRI, and PET CT. The lesions in the stomach are either benign or malignant. And the benign lesions include the leiomyoma, the polyps, neural tumor, and the benign form of GIST, and other relatively rare lesions. Malignant lesions include adenocarcinoma, lymphoid carcinoid, lymphoma, carcinoid tumor, a malignant form of GIST, and finally gastric metastasis. The value of endoscopic ultrasound is almost similar to the value in evaluation of the esophagus. It is of great benefit to reach the possible diagnosis, and also helps in the staging of the tumors, especially the early stages affecting the layers of the stomach. And it can also assess the regional lymph node deposits and has an impact on the treatment procedure, and also in the follow-up of patients after therapy. The CT is extremely valuable here, and one of the main issues is to have adequate gastric distension, either with water or with air, or sometimes we may give contrast material, oral contrast, but water is one of the good contrast media here, and we usually administrate about 750 milliliter of water before the time of examination, and we may add some of water while the patient is on the examination table. Also, we need to inject intravenous contrast material. We need to ensure adequate gastric distension. Sometimes we give effervescence to distend the stomach with air without the need for water, and we may also support this by the hypotonic agents. After CT, we may have 2D and 3D reformation, and we may also have the virtual endoscopy. Most of the gastric tumors are towards the benign side, and they are usually in the submucosa or in the mucosal layers of the stomach. One of these lesions is leiomyoma, and you know that leiomyoma is common in the esophagus, but in the rest of the gastrointestinal tract, especially in the stomach, GIST predominates the benign lesions in this particular area. Similar to the esophagus, leiomyomas are usually in the small size, and the small tumors are usually not aggressive, and these leiomyoma do not have superficial ulcers or internal breaking down. And this is an example of gastric leiomyoma in the fundus, showing homogeneous CT density, and you can see the shadow of the tumor through the air bubble in the stomach. And this is a CT scan of a patient with leiomyoma, pathologically proved in the stomach, and you see a bulboid tumor mass. And if you look carefully here, and you may see dots of air, which are in indication of the presence of minimal ulceration in the superficial part of the tumor, which is not a usual condition for leiomyoma. The next, which is rare, is gastric lipoma, which represents about less than 1% of the gastric neoplasms. Most of the patients are asymptomatic, but because of the tendency to ulcerate, these tumors may present by GI bleeding. If they are large, they may cause gastric outlet obstruction. The diagnosis of lipoma is very easy by CT, by MRI, and by also ultrasound, but in the barium studies they will produce a non-specific filling defect. The fat density on CT and the fat signal on MRI are diagnostic. The next is the neurogenic tumor, which is also rare, and gastric schwannomas represent about 0.2% of all gastric tumors. Most of the patients are asymptomatic, and the CT and MR appearances are non-specific, as you can see here in the homogeneously enhanced lesion within the stomach. And this is the endoscopic ultrasound of a gastric schwannoma, the CT appearance of the tumor showing homogeneous contrast enhancement. Then the glomus tumors, and these are relatively vascular tumors. They are rare and represents about 1% of GI soft tissue tumors. They usually arise from the muscular layer of the stomach, and according to this statement, the incidence is in the range of only 1 in 100 diagnoses of benign gastric glomus, meaning that it is almost rare if you compare it with the GEST tumors. The imaging findings are non-specific, and this tumor may show some calcium, and on contrast enhanced CT you can see significant enhancement. And this is the appearance by endoscopic ultrasound. And this is one of the values of ultrasound. It can show the layers of the esophagus and can detect the site of origin of the tumor. And this is a gastric glomus tumor. And here we see the tumor without intravenous contrast injection. After contrast injection, you may see some significant enhancement. And this is a list of the tumors that can appear hypervascular on CT scan, and they include polyps, gastric carcinoma, carcinoid tumor, glomus tumor, metastasis, gastric varices, and the gastrointestinal stromal tumor. GEST is considered the most common mesenchymal tumor of the gastrointestinal tract, and the most common site for GEST is the stomach, and the age of incidence is around the 40 years old, and small lesions, as I have mentioned, are usually of less aggressive nature. GESTs occur anywhere in the gastrointestinal tract, most commonly in the stomach, less common in the small bowel, and much less common in the anorectum, and the rest of the GI is considered rare sites for GESTs. GEST is usually incidentally discovered because of its small size and relatively asymptomatic behavior. But if the tumor is relatively large, it will have ulcers, and ulcers will bleed, and these are seen in about 50% of the sizable tumors. GEST will show non-specific appearance on barium studies. It will appear as a polypoid mass with a relatively smooth outline and causing a filling defect in the barium-filled stomach. On CT scan, it will appear as a central lesion, and it may show ulcer if it is sizable. Enhancement is relatively apparent, and it may be peripheral. Calcium is known in the GEST tumors, but lymph node enlargement is not a feature of GEST tumor, and this will differentiate malignant GEST from gastric adenocarcinoma, for example. Then aggressive lesions will invade the adjacent structures and will give metastasis to the peritoneum and omentum, or even distant metastasis. This is the CT scan of the abdomen showing a tumor, lobulated outline along the greater curvature of the stomach, and this was a GEST tumor. And here you see a big one originating from the greater curve of the stomach with exophytic extension into the retrogastric area. And here are the differential diagnosis of GEST tumors in the stomach. They include, if they are small, the schwannoma, the leiomyoma, and type 1 carcinoid tumor. Also, the gastric adenocarcinoma and lymphoma may appear as focal masses, but in advanced gastric carcinoma and lymphoma, there should be some evident lymphadenopathy, which is not a feature of GEST, as I have mentioned. Gastric polyps include the post-inflammatory, the hyperplastic, the adenomatous, the hamartomatous, and the eosinophilic granuloma. The hyperplastic polyps are the most common. They represent about up to 90% of the polyps. They do not have malignant potential, and they often seen in cases of chronic gastritis or atrophic gastritis. The hyperplastic polyps may appear sessile or may show some pedunculated appearance. They are in the range of 5 to 10 millimeter, and you see two different cases of polyps. Many polyps here in the fundus of the stomach, and 3 polyps in the antrum of another patient. The adenomatous polyps are considerably rare compared to the hyperplastic polyps. They are commonly pedunculated but may appear sessile, and they are usually solitary, and large adenomatous polyps may contain foci of malignant cells. Then these lesions are like you see here in the barium study, and a sessile polyp resting on the lesser curve of the stomach with a relatively smooth outline. Then bulbosis, gastric bulbosis and hamartomatous polyps are seen in many of the bulbosis syndromes, like Putz-Jeghers and other syndromes that can show many polyps in the gastrointestinal tract. One of the well-known of these syndromes is the Putz-Jeghers, where you can see polyps in the stomach, and anywhere the polyps are of hamartomatous nature. Many of the polyps are pedunculated, and also if you see this very typical pigmentation in the circumoral and in the hand as well, and this will help you to reach the diagnosis. And this is a case of Putz-Jeghers syndrome showing many of the gastric polyps. Then we came to the gastric carcinoma, which according to the literature is rare before the age of 40 years, and it has an intimate relation to the Helicobacter pylori infection, and a good percentage of the tumor is familial in nature, and the most common presentation is anorexia and weight loss. But you may also, the patient may have nausea, vomiting, and gastric outlet obstruction if the tumor affects the antrum. The carcinoma is almost equally distributed between the antrum, the body, and the fundus. And you have a remaining 10% of the tumor which diffusely infiltrates the gastric wall, appearing as a Leionitis plastica. The most common histologic type is the adenocarcinoma. And here you see a barium study with significant irregularity along the distal part of the greater curve of the stomach with encroachment on the gastric lumen, and this will divert the attention towards the gastric cancer, but you should consider that in the differential diagnosis in the lymphoma, sarcoma, and carcinoma tumor may be included. And gastric carcinoma may have a polypoid appearance, and may have an ulcerated appearance, or may diffusely infiltrate the gastric wall. The distal esophagus is involved by carcinoma of the cardia in about 60% of cases, while the duodenum is involved by carcinoma of the gastric antrum in about up to 18% of patients. And one of the presentations is the malignant ulcer with characteristic everted edges, and you see some fine air loculi within the lesion. And in the barium study, one of the classic findings is that you can see amputation of the mucosal folds a good distance away from the site of the ulcer, indicating that there is an infiltrating lesion destroying this site of the mucosa. And this is an example of a gastric tumor near to the fundus of the stomach with metastatic retroperitoneal lymph nodes. The main values of CT in cases of gastric cancer is number one, to identify the site of the tumor and to assess for local spread and to detect the regional lymphadenopathy and also the presence of metastasis. Bulboid lesions, if they are dependent, they will appear as a filling defect, while if they are non-dependent, they will be coated with barium. Then ulcerated carcinoma will show the typical appearance of an ulcer with everted edge and the interruption of the mucosal line. This is a case of gastric antral carcinoma involving the distal part of the stomach with significant luminal reduction and marked irregularity of the gastric wall. Another appearance of bulboid mass which is resting on the gastric wall with irregularity of its surface. And this is another appearance of gastric antral carcinoma and the CT before contrast, and this is after oral and intravenous contrast administration. You see a mass circumferentially surrounding the gastric antrum, and you can appreciate the marked uptake in the PET scan. Also here, you see a diffusely infiltrating tumor in the region of the gastroesophageal junction extending into the gastric fundus, encroaching on the gastric lumen. And this is a case of gastric antral carcinoma with metastasis to the peritoneum. And here you see the nodules concentrated in this particular area of the peritoneal fat with some stranding of the adjacent fat, and this is gastric carcinoma with peritoneal deposits. The staging of gastric cancer in early stages, the endoscopic ultrasound will be of value to see, and the T1 focal thickening without obliteration of the outer layers, and the T2 transmural focal lesion with obliteration of the outer layers, and T3, and you get irregular border with thickening of the gastric wall, and you may notice also affection of the perigastric fat. And T4, you can easily appreciate the extra-gastric infiltration of the tumor into the adjacent organs. The nodal staging, according to the literature, lymphatic spread is found in up to 88% of patients with gastric cancer, and the staging depends on the number of the affected regional lymph nodes. N1, 1 to 5 nodes, N2, 6 to 15, and 3, more than 15 lymph nodes are affected. And if the nodes are detected outside the perigastric area, then consider this M1 disease. And the liver is considered the commonest site for metastasis from gastric carcinoma. You see this lesion affecting the gastroesophageal junction with multiple focal lesions in the liver, but other sites include the lung, the adrenal glands, the kidneys, the bone, and the brain. Then also in advanced cases you can see peritoneal deposits. One of the forms of gastric carcinoma is the diffusely infiltrating type, which is known as Leionitis plastica. And Leionitis plastica is commonly caused by gastric carcinoma, but there are other causes of Leionitis plastica, and you can remember by this abbreviation. Pancreatitis, lymphoma is one of the good possibilities, amyloidosis, syphilis, TB, other types of infection, and most common is gastric carcinoma. And this is Leionitis plastica by CT. You can appreciate significant increase in the thickness of the gastric wall with reduction of the gastric lumen. And this also is seen clearly in barium studies, but you should ensure adequate gastric distension, and you can see that the barium is distending the fundus, and a good amount of barium is seen distal to the stomach, and you know that this is rigid infiltrated gastric body. Then malignant guests will, as I have mentioned, guests occur in about 70%. The 70% of guests affect the stomach, and guest represents about 3% of all gastric malignancies, the malignant one, And one of the main presentations is the gastrointestinal bleeding. And GIST may grow inside the gastric lumen and may grow outside the lumen and may invade the adjacent structures. And this is an example with multiple hepatic deposits. You remember that lymph node metastasis is not a feature of GIST tumors. And this is the patient with a GIST tumor that has been removed surgically, and the patient presents by peritoneal deposit and hepatic deposits as well. Then gastric lymphoma represents the most common site of extranodal lymphoma and about 5% of all gastric malignancies. And one of the entities is the multiple lymphoma, which is intimately also related to the Helicobacter pylori infection. And barium meal lymphoma of the stomach may show almost no findings in the stomach, may be involved by lymphoma, and you got normal findings on barium study. You may got filling defects, you may got this classic appearance in the form of significant thickening of the gastric folds, which includes many of the differential diagnoses, but one of them is the gastric lymphoma. Then Leionitis plastica is one of the forms of lymphoma in the stomach, and also ulcerations may occur. And this is lymphoma of the stomach with significant mucosal fold thickening, as you can see here. And you remember that lymphoma affects any portion of the stomach, and the lymphoma may extend from the stomach into the duodenum in about 30% of cases, and may also, in aggressive cases, invade the adjacent structures. The focal appearance of lymphoma is not an easy presentation for diagnosis, because this is usually mistaken for the commonest gastric carcinoma, and also may be mistaken for GIST tumors. And this is the multiple lymphoma, or lymphoma of mucosa associated lymphoid tissue, which have an indolent course with more better prognosis than the non-Hodgkin lymphoma, the B cell. And this multiple lymphoma may be the precursor of B cell non-Hodgkin lymphoma, and also the non-Hodgkin lymphoma may originate de novo in the stomach. Leionitis plastica is one of the presentations of lymphoma in the stomach, and also you can appreciate the thickening of the mucosal folds. And this will appear on the CT scan in the form of marked gastric wall thickening, significantly encroaching on the gastric lumen. And you should remember that this appearance may also be caused by gastric carcinoma. The lymphoma has no tendency to ulcerate and no tendency to cause gastric outlet obstruction, but it has a good tendency to diffusely infiltrate the gastric wall. And many times you can see evident lymph nodes in the region of the tumor. And the nodes of lymphoma are usually bulky, homogeneously enhanced, and they do not contain calcium. This is the difference between gastric cancer and gastric lymphoma. Carcinoma is more likely to be in the distal part of the stomach. Carcinoma is more likely to cause gastric outlet obstruction, is more likely to extend outside the stomach, invading the adjacent structures, is more focal compared to the diffuse nature of lymphoma, and the metastatic nodes from gastric cancer are usually small, more localized, and contain necrotic centers. And carcinoid tumors of the stomach are considered rare. They are well-differentiated neuroendocrine tumors occurring in the GI and in the tracheobronchial system. Gastric carcinoid represents about 1.8% of all gastric malignancies. And the majority of gastric carcinoids are in of the type 1 carcinoid. You know, we have 3 types, and I will mention in a moment. Then this type 1 is usually seen in patients with atrophic gastritis or with pernicious anemia. Then type 1 carcinoid is this type, which is seen in cases of atrophic gastritis or chronic atrophic gastritis. It will appear as multiple bulboid lesions through the gastric wall, and carcinoid tumors is one of the lesions that show hypervascularity and significant contrast enhancement on CT scan. And this is a case of type 1 carcinoid tumor. You see this lesion and multiple other lesions in the wall of the stomach. The type 2 carcinoid is associated with symptoms of Zollinger-Ellison syndrome due to marked hyperacidity, and the carcinoid tumors here also are in the form of multiple lesions. In the pre-contrast study, you see that the stomach wall is diffusely infiltrated, but after contrast, you see significant arterial phase enhancement of many bulboid lesions markedly encroaching on the gastric lumen. But type 3 carcinoid usually simulates gastric cancer, and this is a solitary lesion, and it accounts for about 13% of gastric carcinoids, and it usually presents by metastatic lesions. And you see in this case a filling defect with thickening of the wall in the gastric fundus, which is also identified in this CT scan, and in the retroperitoneum, and you see many of the metastatic nodes. Then the differential diagnosis of multiple gastric lesions will include carcinoid tumors, polyps, of course, of many types, and also metastatic deposits. Then finally, Kaposi sarcoma is one of the lesions that affects the stomach, and they are most commonly seen in HIV positive patients. It is a subtype of herpes virus, almost exclusively seen in homosexual and bisexual men. And this lesion affects the gastrointestinal tract in about 40 to 50%. It can also affect the skin, the solid viscera, the mucous membranes. And there are many appearances for Kaposi sarcoma in the barium and CT scans, ranging from just the bulboid lesion to diffuse gastric wall infiltration, and the history is very important to reach the diagnosis. One of the criteria mentioned in the literature that you can see bulky lymphadenopathy in the vicinity of the tumor, and these lymph nodes will show intense contrast enhancement, and this may suspect the possibility of the tumor together with the clinical picture. Thank you very much.